Thank you for choosing to view this program titled Peripheral Arterial Disease and Wounds. My name is Pamela Scarborough, and I'm honored to be your presenter today. The disclaimer reads, "This information is provided for informational purposes only. Patient management decisions should be based on a number of factors, including, but not limited to, professional society guidelines and published clinical literature relevant to a patient's condition. Providers are encouraged to rely on their training and expertise, as well as any other and all available information prior to making management or treatment decisions for any individual patient." The objectives. At the end of this presentation, participants should be able to describe the etiology and risk factors for peripheral arterial disease, to recognize assessment parameters for peripheral arterial disease that meet the standards of practice when PAD wounds are suspected, and to list treatment interventions for peripheral arterial disease wounds. Common terminology exists for communication regarding abnormal blood supply to the lower extremity. These terms include arterial insufficiency, peripheral arterial disease, peripheral arterial occlusive disease, arterial disease, and peripheral vascular disease. These terms are often used interchangeably. However, peripheral arterial disease and peripheral arterial occlusive disease are the preferred terms used in current medical literature and are more specific for lower extremity blood flow occlusion in the arterial system. Peripheral vascular disease can be occlusion or disease in the arteries and or the veins, so it's less specific when we use the term PVD. If we're talking about arterial occlusive disease, peripheral arterial disease, arterial insufficiency, PAD and PAOD, peripheral arterial occlusive disease, are more commonly used. Arteriosclerosis and atherosclerosis are processes that lead to peripheral arterial disease or peripheral arterial occlusive disease. Arteriosclerosis is hardening of the arteries with loss of the arterial wall elasticity. This arteriosclerosis process is sped up in conditions such as diabetes. Atherosclerosis, on the other hand, refers to the plaques of fatty deposits, or atheromas, that are formed on the intima or the inner lining of the arteries. Both conditions contribute to peripheral arterial disease. Atherosclerosis is a systemic disease process. Patients who present with claudication due to peripheral arterial disease can be expected to have atherosclerosis elsewhere in the body. A full assessment of the patient's risk factors for vascular disease should therefore be performed. The risk factors for PAD or peripheral arterial disease are the same as those for coronary artery disease or cerebrovascular disease and include the following: diabetes, hypertension, hyperlipidemia, family history, sedentary lifestyle, tobacco use, chronic kidney disease. In addition, it's of interest to note that smoking is the greatest of all of the cardiovascular risk factors. The mechanism by which smoking causes or accelerates the atherosclerosis process is not fully understood. What is known is that the degree of damage is directly related to the amount of tobacco used. It is also of interest to note that low kidney function, which many of our residents have, has also been associated with the development of peripheral arterial disease, and that advanced chronic kidney disease was found to be an independent risk factor for peripheral arterial disease. Arterial ulcers are often painful wounds with pain in the extremities. The pain is typically exacerbated with activities such as walking and with elevation, and somewhat relieved in the dependent position, such as when dangling the feet over the edge of the bed, such as you see here. So one of the questions that you want to ask when we're talking about intermittent claudication that gives you a clue about arterial insufficiency or peripheral arterial disease is pain reproduced with walking distances? Does the resident or the patient have gripping calf pain that is relieved by rest? So this is one of the questions that you want to ask your resident residents. Do your calves hurt when you walk and feel better when you stop and rest? In addition, there's something called nocturnal pain that some people get in the legs, in the lower legs at night. And this wakes the patient up, and it will be relieved by the person sitting up and dangling their legs over the edge of the bed. The reason for this is when we go to sleep at night, the body will shunt the blood from the extremities to the central organs. We increase the peristalsis to the gut and to the colon. The blood pressure is decreased, the heart rate is decreased. All of this is taking place while we're asleep, and blood shunts from the lower extremities. If there's some relative arterial insufficiency, it may become more severe when this happens during the night. In addition, someone may say that their calves are hurting all the time. This is a very serious situation if it is related to peripheral arterial disease and requires that you refer this person to a vascular surgeon. Also, there's something called the positive Berger test that's also known as rhubarb dependency, where you have pallor with elevation, and when you put the foot back down in a dependent position in a light-skinned person, you'll see this red-orange coloring that you'll see with dependency. And we'll talk about rhubarb dependency again in a little while. NF 684 of the State Operations Manual, Guidance to Surveyors, it states that arterial ulcers occur as a result of arterial occlusive disease when non-pressure related disruption or blockage of the arterial blood flow to the area causes tissue necrosis. And it goes on to say in NF 684 that inadequate blood supply to the extremity may initially present as intermittent claudication, which is pain in the calf muscles when walking. Arterial or ischemic ulcers may be present in individuals with moderate to severe peripheral vascular disease, generalized arteriosclerosis, generalized arteriosclerosis, inflammatory or autoimmune disorders such as arteritis, or significant vascular disease elsewhere, such as when there's a stroke or a heart attack. The arterial ulcer is characteristically painful. It usually occurs on the distal portion of the lower extremity and may be over the ankle or bony areas of the foot, such as the top of the foot or toe, or the outside edge of the foot, as you see in this photograph. The wound bed is frequently dry and pale with minimal or no exudate. In NF 684, it states that the affected foot may exhibit diminished or absent pedal pulses. The foot may be cool to touch, have decreased pain when in a hanging down or dependent position, may have increased pain when elevated, may have blanching upon elevation above the heart, delayed capillary refill time, hair loss on top of the foot and toes, and may have toenail thickening. Some of the signs of peripheral arterial disease in association with wounds include slow to non-healing wounds, atrophy or wasting of the skin and muscles, thin, shiny, atrophic skin, loss of hair on the lower extremities, foot and toes, abnormal toenail growth, including hypertrophic nails, such as you see here in this photo, and gangrene. In addition, on the left bottom photograph, you're seeing this pallor or blanching with elevation, which is part of the Berger's test that we mentioned earlier, and we're going to mention again. And the reason I'm mentioning this is such an easy thing for a nurse to do for their head-to-toe skin assessment. You should always, particularly with our population, do a Berger's test where you raise both feet above the heart a little bit. It doesn't have to be high, and see if the foot blanches. If it does, you already know that you've got a problem, and that leg and foot need to be very well cared for. There need to be no accidents. You don't want to hit that leg or that foot on the foot pedal during a transfer to the wheelchair or on the shower chair, and it will help even your CNAs to take better care of your residents' feet and legs when you know on intake that you have peripheral arterial disease. And in older adults, particularly if they have smoked during their lifetime, always suspect peripheral arterial disease in the lower extremity. The State Operations Manual, Guidance to Surveyors, provides guidelines for the assessment and treatment of pressure ulcer injuries and states, it is important that each existing pressure ulcer injury be identified, whether present on admission or developed after admission, and that factors that influenced its development, factors that influence the potential for development of additional pressure ulcer injuries, are factors causing the deterioration of the pressure ulcer injury be recognized, assessed, and addressed, and any new pressure ulcer injury suggests a need to reevaluate the adequacy of prevention measures in the resident's care plan. In Section M of the MDS, Coding Tips MO210, it states that if an ulcer injury arises from a combination of factors that are primarily caused by pressure, then the area should be included in this section as a pressure ulcer injury. So this is really important for us to understand, as this happens frequently in our care setting. We want to call this heel pressure ulcer arterial insufficiency because we won't get an F tag. CMS understands that. I understand that. You understand that. However, that arterial insufficiency made the skin more vulnerable. That is not the primary etiology. The primary etiology has to do with immobility. This heel was not offloaded 24/7, and due to pressure, in combination with the arterial insufficiency, the neuropathy, the diabetes, all of which makes the skin more vulnerable to the pressure, the person gets a heel pressure ulcer. This is a pressure ulcer. It is not a neuropathic ulcer. It is not an arterial ulcer. It is a pressure ulcer due to immobility. Oftentimes, the comorbidities such as diabetes or other skin conditions such as moisture-associated skin damage that you see over here on the right make the skin more vulnerable to pressure. So with each of the examples you see here, there's a combination of factors causing the skin to be more fragile and more vulnerable to the pressure. The heel of the person with diabetes, we've just gone through that, so let's go over to the right and talk about the moisture-associated skin damage. So what we have here is someone who had MASD to start with. And please note, I even put it in green for you up here as a clinical pearl. Moisture-associated skin damage does not have necrotic tissue. It might have denuding or excoriation from scratching. The term excoriation means scratches. With MASD, due to incontinence, it can be very itchy and painful and stinging to our residents, and so sometimes they scratch. But that's not the issue. The MASD makes the skin more vulnerable to pressure. So this is a combination wound related to moisture-associated skin damage and pressure, and you must code it as pressure. Let's talk a little bit more about vascular disease in lower extremity ulcer formation. The incidence of ischemia, decreased blood flow to the lower extremity, peripheral arterial disease, peripheral arterial ischemic disease, or occlusive disease, increases 4 times in patients with diabetes. So with the disease state of diabetes, older adults who may have smoked, and the increased incidence of ischemia, suspect that most, if not all, of your patients with diabetes have some peripheral arterial disease. In addition, an increase in the atherosclerotic process in the lower extremity contributes to the ulceration, but is usually not the primary cause, which we just talked about. The primary cause is decreased blood flow, and then the person gets an injury, a small injury, it can be a small injury, and the wound won't heal because there's not enough blood flow. So wound healing in the lower extremity is dependent on vascularity. Without blood flow, the initial phase of wound healing will not commence. The inflammatory phase, which is actually the second phase of wound healing, will not be initiated. In the MDS, Section M, you have a block to report the total number of venous and arterial wounds. However, there is no reporting mechanism for the details regarding these wounds. Those important details will need to be in your wound documentation that you put in the residence chart. There is a term used in the wound management arena that's called a punched out appearance. And when you hear that term, punched out appearance, we're referring to arterial wounds and peripheral arterial disease. So you're going to do a visual assessment. Look to see if some of these wounds are round, punched out. Look at the lower leg where there may be lack of hair on the leg or the toes or the foot. These wounds are full thickness wounds. As you look at this wound on the right, you see this round punched out appearance, and you also see a tendon being exposed. Now, this is an arterial ulcer, not a pressure ulcer, but we are seeing a tendon in this particular wound. When you do your vascular assessment, you do want to do a capillary refill. You do want to do a Berger's test, which is also known as rhubarb dependency. You need your ankle brachial index, or maybe even higher level vascular studies if they're looking to do some type of surgery for revascularization. The vascular surgeon will do tests and exams beyond the ankle brachial index. For you, however, when you're trying to write a plan of care, you need to know what the ankle brachial index is to see if you even have enough blood flow for wound healing to begin with. And it is recommended for people with diabetes that we do what's called a toe brachial index, because the toes, we don't understand why, and you do the toe brachial index on the great toe with a very small little cuff that goes around the toe. You do the toe brachial index on people with diabetes to check for blood flow, and for some reason the toes are often spared the athero and arteriosclerotic process in people with diabetes. I do want to mention, and I've already said it a couple of times, that taking pedal pulses does not give you definitive information about blood flow to the foot and lower extremity. What you do need to do, though, is you need to go ahead and do your pedal pulses. Do your dorsalis pedis that goes down between the first and second metatarsal, then dives under and goes to the bottom of the forefoot. The artery that goes to the heel is the posterior tibialis, which is below and behind the medial malleolus. So you do want to check this artery. And to be honest, no vascular examination or lower extremity examination is complete without doing pedal pulses. Just don't rely on your plan of care to be complete if you only do pedal pulses. Doesn't give you enough information to know what you're dealing with. Your capillary refill test can be an important and meaningful test. As you see here, this person doesn't have toenail polish. It's obviously probably, well, it may not be obvious, but it's a gentleman, so there's no toenail polish on here. Many of our ladies do wear toenail polish. And you can also see these lovely hairy toes, which is a good indication that you probably have blood flow all the way down to the toe tips. So you're going to do your capillary refill. If someone does have polish on their nails, then you'll push on the fatty pad at the very tip of the toe to do your capillary refill examination. If it's greater, if the blood coming back in once you've blanched the toe, if it takes longer than 3 seconds for the blood to fill back in after you do your blanch test, and that is an indication of some arterial insufficiency. You just don't know how much, and you need higher level vascular studies to give you some objective measurements. In general, the standard of practice is that we do peripheral arterial disease assessment using the ankle brachial index. This is where you take the systolic blood pressure of the dorsalis pedis and the posterior tibialis, both of the arteries that are going into the foot, and you divide that by the systolic blood pressure of the brachial artery. And you use the brachial artery that has the higher systolic pressure. If you use the lower systolic blood pressure, almost all of us have a higher blood pressure on one arm than the other. You want to use the arm with the higher systolic blood pressure when you do your ankle brachial index. Here's the rhubarb dependency again, also known as the Berger's test, which is a nice test to quickly assess for arterial insufficiency. You don't know the exact severity, but you know it's there. So this angle is called the vascular angle, also known as the Berger's angle, is the height or angle that the leg has to be raised before the foot becomes pale when the person is lying down. So on this right foot that's on your left, you see that it is quite blanched with elevation, and you have normal color on the other foot, on the left foot, which is on your right. So this is a very clear indication that this person has some significant arterial insufficiency, and you just need to figure out now how much so that you can write a plan of care. And your ABI, your ankle brachial index, will give you that information. Now we're going to look at treatment for peripheral arterial wounds. Please try not to be disappointed. there's not a whole lot that we can do about this, particularly in our care setting. Conservative management of arterial insufficiency wounds is a challenge to healthcare professionals in any care setting, but especially for those who work in long-term care. Appropriate vascular testing and interpretation is often difficult to obtain, leaving the clinician guessing as to whether there's adequate blood flow for wound healing. The key component to achieving improvement in these difficult wounds is going to be your local care. This includes wound bed preparation. However, one must be cautious and informed regarding vascularity before debriding a lower extremity or foot wound with poor blood flow. Poor vascularity means less blood to the area for wound healing to take place, and you can end up making a larger hole as you do your debridement and no opportunities for wound healing. Other interventions include appropriate dressing selection, perhaps biophysical agents such as electrical stimulation, which is usually used by a skilled physical therapist or physical therapist assistant. There needs to be management to prevent infection whenever you're working with this open wound. There needs to be limb protection during activities such as transfers and bathing, and where appropriate and feasible, a decrease in risk factors such as smoking if you have residents who still smoke. And I have the honor and the privilege of teaching thousands of nurses a year, and everywhere I go, the nurses say, we still have patients who smoke. And my question is always, and they have open wounds? Oh yeah, they go outside after we do their dressing change. Well, be sure you tell them not to expect quick wound closure. And the reason is, and you want to tell them that if they still smoke, first of all, be sure you chart this, because this is one of the reasons the wound's not healing. And surveyors want to know, why aren't the wounds healing? So smoking has a direct, immediate effect, impairing blood flow even more than they already have from the arterial insufficiency, due to two primary mechanisms of actions related to smoking. You get vasoconstriction takes place from the nicotine, and the carbon monoxide knocks the oxygen molecule off of the red blood cell, and wound healing is dependent upon blood flow and oxygen delivery. So in addition to these management strategies, medical, surgical, nutritional, and social collaboration will best serve the resident with these complex cases. The treating clinician, whether they be a physician, nurse practitioner, nurse, physical therapist, we must recognize when conservative measures are not sufficient, and where appropriate, where revascularization or even more aggressive medical management, or even ultimately, some people, unfortunately, will need to have an amputation to save their life. And this will need to be considered. If there is an infected lower extremity that you cannot clear the infection due to poor vascularity. Without good blood flow, you can't even get the antibiotics down there. I don't care if they're IV antibiotics, the best thing in the world. If there's no blood flow, the antibiotics are not going to make it through the arterial system, through the foot, to the foot. So the surveyor says to you, you've been using the same treatment for 6 months and the wound's not improving. Why not? The wound clinician says, because the resident has severe peripheral arterial disease with an ankle brachial index of 0.36. Therefore, there's very little blood flow available for healing. You want to arm yourself with the knowledge to answer questions to the surveyors regarding these difficult to heal wounds in the lower extremity and foot. If there is poor or no blood flow, you will not be able to get the wound to heal without advanced interventions. And even with advanced interventions, many times the wound is not able to heal and the leg or the foot cannot be saved. AMT want to thank you for joining us today. I especially want to thank you for being here and hope this information assists you in recognizing and caring for your people in your buildings who have peripheral arterial disease in general and have wounds from this potentially difficult situation. Thank you. If you're interested, here are the references. I would highly recommend that you read the State Operations Manual Guidance to Surveyors and Section M of the MDS related to wounds, including peripheral arterial disease. Thank you.